Diseases of the blood and blood-forming organs, including the bone marrow, lymphatic tissue, platelets, and coagulation factors, are classified to Chapter 4 of ICD9 CM. However, there are a few exceptions. Neoplastic diseases such as leukemia, which are classified to Chapter 2 of ICD9, along with other neoplastic diseases. Diseases of the blood and blood-forming organs complicating pregnancy, childbirth, or puerperium, which are classified to Chapter 11, and hematological disorders of the fetus and newborn, which are classified as perinatal conditions in Chapter 15. The precise definition or terminology is important in classifying anemias. When a diagnostic statement of anemia is not qualified in any way, review the medical record to determine whether more information can be located in laboratory or pathology reports or in a hematology consult before the code for an unspecified type of anemia is assigned. When it appears that a more specific type of anemia is present, check with the physician for concurrence. Iron deficiency anemias may be due to a chronic blood loss, are coded 280.0. From conditions such as chronic hemorrhagic gastrointestinal conditions or menorrhagia, or to inadequate intake of dietary iron, coded to 280.1. Iron deficiency anemias are classified in category 280. If the cause is unspecified, code 280.9 is assigned. Other deficiency anemias are coded to category 281, with a fourth digit indicating the specific type of deficiency, such as pernicious anemia or B12 vitamin deficiency. Acute blood loss anemia should not be coded as postoperative complication without physician identification. Postoperative anemia without specification of acute blood loss, 285.9, anemia unspecified. Postoperative anemia due to acute blood loss is coded to 285.1, acute post-hemorrhagic anemia. When neither the diagnostic statement nor the review of the medical record indicates whether a blood loss anemia is acute or chronic, code 280.0 should be assigned. Patients with chronic illnesses are often seen with anemia, which may be the result of a cause of the healthcare admission or encounter. Treatment is often directed at the anemia and not the underlying condition. Codes for this type of anemia are classified as follows: anemia in chronic kidney disease, 285.21, plus a code from category 585. Anemia in, due to, or with neoplastic disease is coded to 285.22 plus the specific neoplasm code. Anemia of other chronic disease is coded to 285.29 with an additional code for the chronic condition causing the anemia. These codes may be used as the principal or first listed diagnosis when the reason for the encounter is to treat the anemia. They may be used as secondary diagnosis codes when the reason for the encounter is to treat the underlying chronic disease or another condition. Anemia due to chemotherapy is a rare hemolytic process and not truly aplastic. These anemias are usually short-term change and do not reduce the bone marrow cellularity to a point of aplasia. It is not necessary to additionally report the E code because it's being an adverse effect of a chemotherapy drug is included in the anemia code. However, providers may opt to code the E code for internal data collection. Also, it is not necessary to assign a code 285.22 for anemia neoplastic disease because the code 285.3 already includes this information. Anemia due to drug in which the drug is not specified would be coded such as you would code to the type of anemia or code to 285.9 if the type of anemia is not specified. Anaplastic anemia is caused by a failure of the bone marrow to produce red blood cells. This condition may be congenital, but usually idiopathic or acquired, or may be due to an underlying disease such as a malignant neoplasm or an infection, such as viral hepatitis. Pancytopenia is a type of aplastic anemia that represents a deficiency of all three elements of the blood. When a patient has anemia, deficiency of red blood cells, neutropenia, a deficiency of white cells, and thrombocytopenia, deficiency of platelets, only the code for pancytopenia should be assigned. That code is 284.19. Some physicians may not say pancytopenia, but may list anemia, neutropenia, and thrombocytopenia. In these situations, it is appropriate for you to assign the pancytopenia code. When the pancytopenia is drug-induced, ICD9 distinguishes whether it is due to anti-neoplastic chemotherapy, 284.11, or another drug, which is coded to 284.12. Code 284.09, other constitutional aplastic anemia, would be assigned if the pancytopenia was congenital rather than due to a chronic disease. Do not assign code 284.1 if this pancytopenia is due to bone marrow infiltration, code 284.2, hairy cell leukemia, code 202.4, or HIV disease, code 042. Sickle cell disease or anemia, code 282.6, is a hereditary disease of the red blood cells. The disease is passed to a child when both parents carry the genetic trait. Sickle cell trait occurs when a child receives the genetic trait from only one parent. Patients with sickle cell trait, code 282.5, do not generally develop sickle cell disease. They are carriers of the trait. When a medical record contains both the terms sickle cell trait and sickle cell disease, assign only the code for sickle cell disease. Code 282.62 HBSS disease with crisis is assigned when the vaso-occlusive crises or other crises are present. An additional code is assigned to report the type of crisis, such as acute chest syndrome, code 517.3, or splenic sequestration, code 289.52. If a condition such as cerebrovascular embolism occurs, a code should be assigned to indicate its presence. Another possible type of sickle cell disease is sickle cell thalassemia. Specific codes are available for sickle cell thalassemia with crisis, 282.42, or without crisis, 282.41. Additional codes are assigned when the type of crisis is specified. Thalassemia is a genetic blood disorder resulting from a defect in a gene that controls the production of one of the hemoglobin proteins. Defective gene is inherited from both parents and is considered thalassemia major. When the defective gene is inherited from only one parent, it is known as thalassemia minor. These individuals are carriers and usually do not have symptoms. As you can see on the slide, there are many forms of thalassemia. Coagulation defects are characterized by prolonged clotting time. Some defects are congenital in nature, while others are acquired. Hemorrhagic disorder due to intrinsic circulating anticoagulants, antibodies, or inhibitors are coded to subcategory 286.5. Results from the presence of the circulating anticoagulants in the blood that interfere with the normal clotting. These anticoagulants are usually inherent or intrinsic in the blood like other coagulation defects, but occasionally may be augmented. The category 286.5 has been expanded to identify the type of defect. Bleeding in a patient who is being treated with coumadin, heparin, or other anticoagulant does not indicate that a hemorrhagic disorder due to intrinsic circulating anticoagulant is present. Assign a code for the condition and the associated hemorrhage with an additional code of E934.2 for anticoagulants to indicate the responsible medication. Code 286.5 is not assigned unless the physician specifically documents a diagnosis of hemorrhagic disorder due to circulating anticoagulants. Heparin-induced thrombocytopenia, also known as HIT, is one of the more severe side effects of heparin therapy. Heparin therapy is widely used to prevent and treat clotting disorders. Heparin may trigger an autoimmune condition of severe platelet deficiency with clot-related complications. Heparin-induced thrombocytopenia is assigned to code 289.84. Hypercoagulable state refers to a group of acquired and inherited disorders. These disorders are caused by increased thrombin generation. There is an increased tendency for blood clotting, and there may be fibrin deposition in small blood vessels. Primary hypercoagulability states, code 289.81, are inherited disorders of specific anticoagulant factors. Secondary hypocoagulable states, code 289.82, are primarily acquired disorders that are predisposed to thrombosis. Prolonged prothrombin time or other abnormal coagulation profiles should not be coded as a coagulation defect. If the patient is receiving coumadin therapy, however, a prolonged bleeding time is an expected result, and therefore code 790.92 is not assigned. Note also that coumadin is not a circulating anticoagulant. It induces anticoagulation through other mechanisms. Thrombocytopenia in the blood cells Thrombocytopenia is a deficiency in the blood cells that help blood to clot. Post-transfusion purpura is the recipient's response to produce antibodies that destroy the transfused platelets, as well as the recipient's own platelets, to produce a severe thrombocytopenia in HPA-negative women who were immunized during a previous pregnancy or transfusion. Code 287.41 is used for post-transfusion purpura. White blood cells, WBC, or neutropenia, is the deficiency of. White blood cells play an important role in the body's immune system by fighting off infection. Many different diseases can affect white blood cells. Diseases of the white blood cells are primarily classified on the basis of whether the white blood cell count is low or elevated. In addition, more specific codes are available depending on the type of blood cell affected. And here you will see various types of decreased white blood counts. Unspecified leukocytopenia is coded to 288.50. A decrease in lymphocytes or lymphocytopenia is coded to 0.51, or other decreased white blood cells, including basophils, eosinophils, monocytes, or plasmacytes, are coded to 0.59. And elevated white blood counts are coded to subcategory 288.6, and these include leukocytosis, elevated lymphocytes or lymphocytosis, a leukonoid reaction including a basophilic, lymphocytic, monocytic, myelomocytic, a neutrophil leukemia reaction coded to 288.62, monocytosis, plasmacytosis, basophilia, As you can see all the different codes here. It is important to remember, as in with any other system, you cannot code just based on the laboratory findings. It is important that you have physician concurrence regarding the specific lab results and whether or not a code is appropriate.